My name is Tammy Hatfield. I'm a women's health nurse practitioner. I am new to FMI, but I am not new to the Valley. I've been here for 20 years now, practicing women's health for 34 years, and the last 24 years of that as just a women's health nurse practitioner. I specialize in hormone management. It's my passion. It's what I'm get very excited about. It's like my soapbox. Like I get on certain subjects and I'm like, oh my God, really? Is that all they're doing for you? It's still surprising to me that women don't know that there's still options. We got told a lot of things and we'll talk about that later tonight. But I've been with FMI since June. Did I start in June? I can't remember. June. And just needed to be with other providers. I'd been running my own practice for 15 years, solo. And I just really wanted to get with other providers who understood more about treating things more functionally, getting to the root cause of things, versus just slapping you with a bunch of medications that you're not really interested in doing, which is the main reason why I do what I do in hormone management. I like to start with the basics. They're probably things you've already heard about and you know about, kind of be like, oh yeah, that's what it is. But it's just really important to understand what your hormones are doing, what they're doing at certain stages in your life, and how they change and start causing problems for us at all different stages. And I think we like to slap a lot of labels on things that are not necessary because we kind of villainize hormones a lot. And my soapbox is to not villainize hormones and say that they're bad and that they're not good for you. I like you to understand what they really do for your body and why bioidentical hormones are a great option for women. So in talking about, God, this kind of echoes in here, doesn't it? And talking about hormones just in general, so from the time that we hit puberty, we have hormones in our body. We are hormonal. And I always hate it when everybody thinks that calling somebody hormonal is like this bad thing, because we do. Like, God forbid your husband say you're hormonal that day, because he might find the butcher knife somewhere nearby. But we are hormonal. That's what we're supposed to be. That's what defines our femininity and makes us women, is our hormones. And so, the first day of our menstrual cycle, all of our hormones go to zero to signal that lining to shed from the body. Starting about day 5 to 7 into our bleed, we then start having estrogen kick back in and tell that lining to start building back up again. Estrogen gets a really bad rap. And we hear this term estrogen dominance all the time, how bad it is. You're estrogen dominant, you have all these symptoms, but we truly are supposed to be estrogen dominant the first half of our cycle. Otherwise, we would never build up a lining in order to have a period. So we need estrogen. Estrogen dominant the first half. The second half is when we become progesterone dominant. And that progesterone is to tell that lining, I usually say shut up and stay there, but be quiet and stay there till the end of the month. And then we start the process all over again. And that is a normal menstrual cycle for us. As we age, those hormones start to change. And environmentally, there's other things that come into play that change our hormones as well. And we can get into a lot of detail with that later. But as we start getting into the aging process, when we get to about age 35, that's when progesterone levels start to decline. And they'll decline earlier as well as a result of pregnancy. So regardless if your pregnancy ends in a full-term delivery or we have a miscarriage, our progesterone goes up sky high, not sky high, but it goes up to keep that pregnancy in check. That's what tells the lining to be quiet there and support the pregnancy. And we become very much producers of progesterone. It's the progestational hormone, progesterone, that kicks in at that time. After every pregnancy, our hormones reset and we have less production of progesterone each and every pregnancy. And that's why you'll sometimes hear women get to a certain pregnancy number, just depending on them. And they'll go, you know what, after my last baby or baby number 3 or baby number 4, I felt like everything was a disaster afterwards and I never felt like myself again. And I'm like, that happens a lot. And a lot of women describe that. What unfortunately happens is that they'll either develop like postpartum depression, or their blues last a lot longer than they should have been lasting. Or they'll get told, well, we'll just put you in an antidepressant and we'll get that all fixed up for you. And that's not always the answer that I tell patients is the best answer. Now, they have their purpose. There is a good reason for people to be put on antidepressants in their lifetime, but we're not Prozac deficient. We're not Zoloft deficient. We're usually hormonally deficient. And that's when we want to add in those things. So a lot of patients come to me either after their pregnancies or they start to get into their late 30s, early 40s. When we get past about 40, our estrogen then starts taking some big highs and lows. And that's where we start to have a few more symptoms start to come into play. Not for every person. There are women who go through menopause and go through perimenopause without symptoms. They don't come to see me. It's the ones that are having the problems that come to see me. And so those big fluctuations in estrogen then can add to other symptoms of my PMS is now, instead of being 2 days, it's 7 days or it's 10 days. Or some women also come in and tell me I only have one good week out of the entire month. Those are the ones who really need my help. So the other things that will start happening is you may have heavier periods. You may have spotting in between your cycles. Instead of it just being at the end of the month, we now have spotting, or we develop fibroids, or we start to feel like we're more emotional. We've literally had patients, I think when I very first came to town 20 years ago, we had 5 patients who had come in who were all diagnosed as bipolar. And by the time we got done evaluating them and looking at their hormones and treating their hormones, we discovered, well, I don't think you're bipolar. I think you were hormonal. And now we've gotten things straightened out. Sad part is 3 of them, medical providers said, I really do still think it's just in your head, which is such gaslighting to women all the time, telling us that it's in our head. And then 2 who actually apologize and go, wow, this is going to help me with my next patient who comes in like this. Then I know that I need to maybe look at hormones for them. So when we're changing and evolving, the unfortunate thing in medicine is that we don't get taught about dealing with hormones and actually treating them. It's very rare. It's now starting to kind of ramp up a little bit. There are some medical schools that are starting to get more specific with treating it. But literally what we are still teaching in our schools is that if you're under the age of 50 and still having a period and you have these symptoms of like, I'm having night sweats, I'm having menstrual migraines, my periods are really heavy, I want to kill people the week before my period, they'll say, well, let's put you on an antidepressant. Or my sleeping is off. Well, let's go ahead and give you a sleeping pill. Oh, you've gained weight. Well, I got a bunch of new drugs that I can give you for that too. But we forget that there's actually hormones at the core of this, and there are things that we can do with the hormones. They're not a 100% fix for everybody because there are things that we can do to help them either work or not work. And those are I call them the cornerstones that help to support your hormones. And the cornerstones of any hormonal plan is looking at, are you sleeping? Which many of us don't sleep, but when we start getting at certain points in our hormonal journey, even if it's just a couple of days out of the month where it's like at ovulation or just before your menstrual cycle, we might have sleep disturbances at that time. Your nutrition is super important at every stage of our hormonal journey. We cannot have good hormone balance without good nutritional balance, and it changes. What we needed in our 30s is not needed in our 40s, and it's probably not the same thing that we need when we hit 50. The other thing that we need is exercise. Our muscle is a great metabolizer, and it's super important to realize that it's going to change and our body composition is going to change. You can be the exact same weight, and you hit menopause. I've hit menopause. It hits you like a ton of bricks. And for people to say, I don't see the gals who, there are gals out there that they just sail right through. I'm not one of those people. The people that I see are not those people. But your body composition literally changes as a result of those hormone fluctuations, particularly in terms of estrogen and testosterone. And we can get into real big specifics if you'd like to get into the details of that. I don't have any problem explaining that. So, again, sleep, nutrition, exercise, and then connectedness. And what I mean by connectedness is what's going on in our interpersonal lives, whether we're having extra stress or we're dealing with becoming an empty nester and not adjusting very well to it, or changes in job, or changes like you moved and you don't have friends who are a support system for you anymore. All of those things make a tremendous impact on your hormones, and so does your intimacy. I still haven't figured out if the whole article was written just from a male's perspective or a female's perspective. But there's some great articles out there that talk about the fact that our intimacy or lack of it will determine how soon or how late we enter menopause. Because every time that we engage in intercourse, and I'm already jumped way ahead of myself, but we'll kind of dive into it, is that intimacy resets your hormones. And it's a really interesting thing. Having been in hormone management for so many years, and now probably for the last 15 years, I've dealt with male hormones as well, because once I fixed the wives, they wanted their husbands or their partners to come in. And that's where it kind of spurred into that. So I have a secondary certification in anti-aging medicine, which allows me to see men for hormone replacement. And I can always tell when things or the dynamics start to change in the household by looking at the numbers, because all of a sudden his testosterone starts going up way higher than I imagined, because that was not the amount that I gave him, but they're becoming more intimate with one another, and that resets hormones. So all of those 4 things, if I can give you all the hormones in the entire world, but if we have one of those cornerstones out of balance, your hormones aren't going to sit the way that they're supposed to. So that's why I love hormones so much. So there are, let's talk about the definition of perimenopause and menopause, because that gets really confusing. I get a lot of patients who come in and go, will you please just tell me if I'm in menopause? Have you had a period? Yeah, I'm still having periods. Well, you're not in menopause. Then they get frustrated because I've got this symptom and this symptom and this symptom and this symptom. And you're like, you're perimenopausal. Well, when did I become perimenopausal? I can't give you the exact date, but if you're over the age of 35, remember, progesterone levels start to decline. So by definition alone, we're perimenopausal from 35 on. Whether or not you need treatment or your symptoms are severe, just kind of depends on you. What's going on in your environment? How are you adjusting to things? Do you have extra stressors that may be contributing to more of your hormones being out of balance? Stress is one of the biggest things that we deal with patients feeling like their hormones aren't in balance when everything kind of looks like it's normal. On paper, it looks like, wow, your hormones look like they should be really good. And they're like, no. I'm like, then how much stress do you have going on right now? Because stress in and of itself taxes the adrenal glands. So the adrenal glands don't kick out a key hormone that most women don't get checked, which is DHEA. And DHEA can't be produced, which then it affects your testosterone levels. Then we have less testosterone being produced in the system. They're all related to one another. And then we kick out more cortisol. Well, cortisol dampens the effectiveness of your hormones. So if you are on the best hormone regimen that we could possibly get you on, but you have a lot of stress going on in your life, it's going to dampen how effective are those hormones going to be in your system. So it's really hard. We always talk about the fact that we cannot change your stress. You can only change how you're responding to your stress. And I always kind of giggle with some of the girls and go, honey, I cannot write you a prescription to live in a bubble down by the ocean, away from everything around you. No husband, no kids, nothing. I wish I could. I have written that on a script for a lady just as funsies to give to her husband. But one of the things that I really like about FMI was meeting with Lois, who is one of our health coaches. And I had my little aha moment and talking with her, because she's like, no, I can teach patients how to do specific breathing techniques and how to start responding different to their stressors, because there's heart rate variability that happens where your heart rate changes when you're dealing with a lot of stress. And doing proper breathing, we sometimes forget to breathe the way that we're supposed to, and which sounds really just simple, right? That I need to learn how to breathe. But how many times do you sit there and go, when was the last time I took a deep breath today? And you're thinking about it, you're like, I don't know when I took a last deep breath. So, but she is a wonderful resource for our clients. So you can't change your stress, just how you respond to it. Easier said than done for women, because we don't compartmentalize things very well, as we know, right? Right? Everybody knows that. So it's the funny thing about the differences between men and women. This is something my husband and I always got on a big kick when we were talking with our clients in our couples class, is that literally, if you've ever talked to your husband or your significant other who's a male, who you say, what are you thinking about? And he literally looks at you and says, nothing. And in your head, you're going, I've got 15 million thoughts going on. How could you not be thinking about something? But that's how fundamentally different that we are when we're dealing with our stressors, is how men can compartmentalize. And we have to work on it really hard to compartmentalize things. But getting your stress under control is such a key part to helping with your hormones. So menopause, perimenopause, we're perimenopausal from 35 on. Menopause is defined as 1 year without a period. Now, we run into some obstacles with that when women have had either progestin IUDs in place like Mirena or Liletta that causes them to not have a period. They won't sometimes know when they hit menopause, or if a woman's had a uterine ablation where they don't bleed anymore as a result of a surgery to help basically get that lining to not produce a lining anymore. Or if a woman's had a hysterectomy, she still has her ovaries and producing hormones, but she doesn't have a period to guide us as to when she's actually in menopause. And all three of those pose a very interesting situation with what's going on in our community with other providers giving prescriptions out. Because as soon as you start to say that you have some hormonal symptoms, if you've had a hysterectomy, the only option is what? Does anybody know what they usually give a woman who's had a hysterectomy? The only thing they give you, now mind you, we have a lot of hormones. We have estrogen, and it's not just estrogen. There's several different types of estrogen and estrogen metabolites in our body. We have testosterone, we have progesterone, we have DHEA, we have oxytocin, we have pregnenolone, we have like a whole host of these hormones. But if you've ever had a hysterectomy, the only option that they want to give you is estrogen. That's it. They don't want to give you anything else because we're taught in school that the only hormone that you need is estrogen. Because if you don't have a uterus, you don't need progesterone because progesterone is to protect the lining of a uterus. And if you don't have a uterus, why should I give you progesterone? It's not a great thing. So that puts women into a very hormonally deficient because all of our hormones work together in a symphony. They're meant to work together. Progesterone is a beautiful, wonderful hormone when it's micronized natural bioidentical progesterone, not synthetic progestin, which is marketed under the name of Provera. There's a lot of problems with that one. But micronized natural progesterone helps with your hair, nail, and skin health. It helps you to sleep at night. It helps to balance out estrogen so that you don't get like menstrual migraine symptoms coming back after you've had a hysterectomy because they've just put you on estrogen. It helps balance out the weight because it's a natural fat metabolizer. We call it the happy hormone. It helps you with anxiety. It helps you with just feeling more like yourself. And so to tell women just because they've had a hysterectomy that they don't get progesterone is not a great thing. Years ago, when I very first started into becoming a nurse practitioner, I had a gal who was training me who had her hysterectomy patients on birth control pills. And I was like, what in the world? Why do you have them on a birth control pill? They're obviously not going to get pregnant. And she's like, it's because they feel better when they have both estrogen and progestin. Now, she was onto something. It wasn't the right route to go completely, but she really was onto something because when you have young women, especially women who are like in their early 30s who are having full-on hysterectomies where they have nothing left anymore and they're just giving back estrogen, they don't feel very good afterwards. And so we need all those hormones to work together. So those are kind of the definitions of menopause. Average age of menopause for most American women is around age 52. Give or take a few years on either end. We're starting to see more women in their mid to late 50s who are still having menstrual cycles, who are not happy about it. Can't really stop it. We want you to have those. The benefit of still having your hormones that are enough to produce a lining and still have an actual menstrual cycle actually is protective. It helps with bone protection, cognitive protection, and cardiovascular protection. So we want, as long as you can produce them on your own, we want you to produce them on your own. When you need them, we like to give you options. Again, I use what was referred to as bioidentical. Bioidentical just means that it's going to match your own chemical structure. It is not the same thing as Premarin. Very interesting that we're still having people prescribe Premarin. We've known for a very long time that that is not the best form of estrogen to be giving our patients. The pharmaceutical company played a little joke, so to speak, is what I call it. Premarin actually stands for pregnant mare's urine. P-R-E, pregnant, M-A-R, mare, I-N, urine. And it literally comes from pregnant mares. And I got ethical issues about that. It's nice that we're not seeing providers prescribe it anymore. That molecule does not match the human molecule of estrogen. They actually add 16 different little arms to it to get it to fit into the human estrogen. And what it then does is that if you have problems with it, it's going to take about 6 to 8 weeks to get out of your system because it's got such a high affinity for holding on. using bioidentical hormones that mirror your own hormone structure. If we have a problem with them, the beauty is I can have you stop it, and literally 3 days later, it's completely out of your system. So if we need to adjust a dosage, or God forbid you ended up with a side effect that you didn't like, and usually side effects from bioidentical hormones are more based on your dosaging versus the actual medication causing problems with symptoms. It's very rare that it's actually the medication itself that's causing the symptoms. It's usually a dosage thing. So when we address them, literally 3 days later, I can have a different result with it by just manipulating it just a little bit. So pregnant mayor's urine, like I said, I usually joke with patients, I'm like, girl, you do not look like a horse, and I am not a veterinarian, and we are not staying on this medication. So oral estrogen of any type, though, does run the risk of strokes and blood clots. And that's why you'll see so many providers nowadays try to stay away from giving oral estrogen to patients. It processes through the liver on its first pass in the body. We call that a first pass effect. And that's where clotting factors come from. So there's a 1% increased risk of strokes and blood clots for every year that you're on an oral estrogen. So if we can avoid it, even bioidentical estrogen runs that same risk. If we can avoid it, there are numerous topicals that we can use that are both pharmaceutical. And then we also use a lot of compounded hormone therapy as well. Anybody not familiar with compounded pharmacy, what that means? No. Okay. So compounded means that they take the dry USP regulated ingredient, and instead of it going to an actual pharmaceutical company, a compounding pharmacy who has special training in mixing up hormones will make it for the patient. I like compounded because then I can give you more titrated dosages and like fine tune things. Not to say that I can't do that with some of the things that are available pharmaceutically. We're just a little bit more limited with them. Like, for instance, if you have a peanut allergy, I can't give you the normal progesterone that you can get from the pharmaceutical company because it comes in a peanut oil base. Also has a little bit of soy oil. So if you have soy allergies, you really shouldn't be doing that one either. But with compounded, we have an infinite amount of different things that we can do with progesterone. Progesterone can be a troche, which is like a lozenge. We can do drops. We can do fine tune the dosage because the only dosages are 100 and 200 milligrams. And then from there, we also have estrogen. We can do suppositories. We can do topical gels. We can do our vaginal creams as well. There's a whole host of things that we can do. We can fine tune the dosage to anything that we want to do for our patients. If you have any fear or an inkling that you have a worry that if you start on hormone replacement therapy that it will cause something ill, right? I don't want you to take it. And the reason being is because we've done the studies with twins where we have twins. One twin thinks that they have a disease process and the other one thinks that they don't have it, and they develop the problem. So that power of the mind is super, super important. And that's why anytime I get a patient who's starting to feel a little like, all my friends are telling me not to do this, or my mom's telling me not to do it, or I'm just like, let's talk about some other alternatives that you have, other things that we can do. A lot of times women are just coming into me because the one thing that bothers them the most is that they're dealing with vaginal dryness. And they're like, I was told I can't do any hormones. I have a very safe hormone I can give to someone to help with that specific problem. One that's what we call estriol. Estriol is what we refer to as an end metabolite estrogen, meaning it's down at the very bottom of the cascade of how all the hormones convert, and it cannot convert itself into any of the bad estrogens. So that estriol helps with elasticity, moisture, and responsiveness of the tissue, and it's given very safely in patients with breast cancer, even with breast cancer. Yeah, so I feel very safe in giving it to patients in general. So it's kind of figuring out, I like to find out what is the main objective with seeking hormone replacement therapy, and what is your goal in wanting it? And sometimes it's just something just as simple as like, I just don't want to feel dry there anymore. I'm like, I can fix that. And there's other things even besides the estriol. If somebody's still a little leery with estriol, we have hyaluronic acid that can be used in suppository form or cream form that can go there. There's a couple of other things that we can do to help out with the vaginal tissue besides hormones. Yeah, absolutely. So one of the number one reasons that women come to see me is because their sex drive has depleted. And it can be at any time in their life, whether it's postpartum after having a baby, or whether it's getting into perimenopause, or whether or not it's postpartum or postmenopausal and things have changed and things don't feel very good anymore, or they're less responsive. Every stage in our relationships and our age changes our sexuality. And if you think about it, just think back to when we were young and first in love and all the butterflies are going off. We literally at that stage in our life even our vital signs are different. Our heart rate goes up when that special person walks in the room, and our blood pressure goes up a little bit, and our pulse rate goes up a little bit. And it's because it's still those flutters, right? As we get further into being comfortable in our relationships, having babies or not having babies, or changes of jobs or changes of age, all of our sexuality changes. And women get frustrated and they get sad by it because they're like, I'm not doing something for my partner that my partner wants. I always have to take it back to asking more questions, because a lot of times what women get told, and they come to me all the time, my doctor told me this was normal and I was just supposed to live with it. I'm like, do you really want to live with it? Like, we're young. Let's have fun with it still. I hate it when women get to menopause. They're empty nesters. Kids are out of the house and they don't have a sex drive. And you're like, this is the time you're supposed to be chasing your husband around the house. Like, this is the time where we get to kind of reinvent what our intimacy is like with our partner. The other thing about intimacy, though, is figuring out what it is that is your definition of what a healthy intimacy is. Is it just once a week? Is it once a month? Or is it something that you want to be more intimate with your partner? What does it do for you at this point? Or am I not getting anything out of this, and that's why I don't want it anymore, because now I can't achieve an orgasm, and why bother, because it's a bunch of work. Because I got to get out the KY, I got to close the door, I got to make sure that the lights are off because I don't want him to see my tummy. You know all this talk that we do in our head, right? So at every stage in our life, it changes. When we're having children and we have little ones running around the house, we use up that hormone that is our passion hormone to nurture and care give for our children. That's oxytocin. Those of you who've had children, you know that there's at some point where you're like, I just don't want to be touched anymore. I have this kid on me all day long. I need to stop. And you're just like, it shuts down what's going on with the intimacy with your partner. It's normal. There's nothing wrong with you. You are not broken. There is nothing wrong with that, because we know from a biophysiological standpoint, our oxytocin is being used up to give for our children. When we start to get at later stages in our life, I always ask the question, how old are your kids? And what are their sexes? And where is their bedroom in proximity of your bedroom? And they all, well, what's kind of like, we need to know these things. As our children become adolescents and now start understanding about sexuality and what it means to have butterflies in it, it throws another spin on our sexuality, because now we're like, oh crap, what if they walk in? Or what do they know that I'm being flirty with my husband, or what's going on? Or like, I don't want the kids to know that I'm being flirty with him, or what's going on. There's all those little things, and I don't want them to hear us. God forbid, we need to be quiet now, and that's not a good thing anymore. Literally, the proximity of the bedroom is important, because if you're sharing a wall with your child who's a teenager, you certainly are not interested in having sex, because you know that wall is not very soundproof, right? So there's all these different layers of different times in our lives where our sexuality is being affected. Again, you're not broken, because usually the question is if I put you an order in for a romantic vacation, away from the children, away from work, would you have sex with your husband? Most women say yes. There are times when they say no, and then we have a bigger problem. We need to talk more about things. But if the answer to that question is yes, of course I would, then we know that it's environmental. Something is going on at home or with work or anything else that's going on at house that can cause problems with having a libido. Stress is the #1 killer of a libido for both men and women. Why? Because all those hormones get changed, right? We talked about that earlier with cortisol. It's going to affect your hormones. So when menopause hits, then we got a whole nother layer that we have to deal with. Everything from dryness to changes in the vulva, changes in the clitoris, changes in our response time, what's going on down there, and whether or not we have desire or arousal, and where all those fit into play. So we have to break it all down. If I have dryness, fix it. Because the thing is that if you ever have problems with any pain that's associated with intercourse, and it doesn't matter at what age you are, as soon as we start associating pain with intercourse, we shut down that desire. Because I always refer to it as the hot pot syndrome. Do you want to stick your hand in a hot pot? I don't want to stick my hand in a hot pot. And if it hurts, why would I want to engage in it if it's going to hurt? Because pain associated with sexuality becomes more of being tense, not being able to orgasm anymore because now we're tense because it doesn't feel very good, or it's just too painful and we want to avoid it at all costs. So if there's pain associated with it, you have to be with a provider who can address that directly. Otherwise, we can never get your libido back. I can't fix a libido if pain is associated with it. The clitoris, 70% of women derive orgasm from clitoral stimulation. 70% of us. So when I'm talking about have they been able to achieve an orgasm, if we quit achieving an orgasm and we're not able to achieve orgasm anymore, that starts to send that signal to the brain again, do I really desire it? Because orgasm in and of itself stimulates oxytocin release. Doesn't matter if you're a man or a woman. Oxytocin release causes us to want to love and nurture our partner and go, that felt good, let's do that again sometime. I'll put you on the calendar of 15 days. No, I'm just kidding. But that's what stimulates oxytocin. In men, it reboots their testosterone. So when you think about it in that aspect, one of the interesting things that happens with men, and please don't go home and share this with if your partner is male, I don't want you to go home and go, so Tammy said, no, Tammy said, what happens is if he is not engaging in intercourse for 7 days, his testosterone will do this, and it starts to tank at the end of the 7 days. And then it'll try to spike itself to get him to push him to go have sex. Over time, if he doesn't, that testosterone starts dropping below baseline. And we don't know when that is. We don't know if that's, has it been 10 weeks that it has happened, or is it just 2 weeks that it's happened? We just know that starts happening. Now, what happens when a man's testosterone kind of spikes? Kind of gets a little grouchy, right? Are you really interested in having sex with him? He's grouchy. No, we're not. So you got to think about that too. The interesting thing with men, that rebooting of the testosterone is important, of course, for their entire health. But we know there's some statistics. Again, we do not discuss these statistics with our male partner. We keep them to ourselves. If he's engaging in sex at least 3 times a week, it lowers his risk of dying from a heart attack by 60%. It's pretty significant, right? Lowers his risk of aggressive prostate cancer. That's kind of significant too. I've been married 34 years and to the same man. And I kind of like him still. But he always jokes about the fact if we're not intimate, he's like, you're just killing me slowly. I'm like, yes, I am. Isn't it fun? You got a lot of insurance. But if that intimacy is a thing that does help with hormones, I always tell women also do it for selfish reasons, for yourself, because we don't think about that. We're always like, oh, let's please him, make him happy, make sure he's taken care of. No, do it for your reasons too. It does reset your hormones as well. We know that women who are engaging in intercourse at least twice a week, they delay menopause longer. That's the study that I'm not sure if a male wrote or a female. I still need to look that up. We know that it increases serotonin production, so it does help with your happiness hormone, which is our neurotransmitter, serotonin. There's a study that was done on leptin levels and satiety, but for selfish reasons, because of the fact that it does reset your hormones and it does help with your oxytocin levels. Helps to keep the tissue healthy, more blood flow to the area. So orgasm, if we're not achieving it, like I said, then the desire goes down. The problem with menopause is that our intensity of orgasm starts to diminish. Our length of time that it takes to achieve it starts to diminish. And then when you start thinking about the whole dynamics of relationships, if he's starting to go through a little bit of andropause and having some erectile issues, and you're taking longer to achieve a climax, you see where this becomes a big problem. So that's why it's important that if there is an issue with it, if he could be more willing to come in and see a provider who deals with his hormones as well to help with that, as well as you. And so again, not broken, just changes. Things are changing. Everything is changing physiologically. So the clitoris, even though we think of it as being just that little nubby at the very tip top there, it actually is a very big organ. I need to get one of the actual, um, well, they have puppets and all kinds of things. I thought those were a little much, but the clitoris itself extends about an inch to an inch and a half back into past where you see the little nub at the top. And it has what we call clitoral horns that go down through the vaginal on each side. So back behind the labia. So as we start losing elasticity of that skin and responsiveness of that skin, it starts to atrophy a little bit. It does get smaller over time. Hormones can help with keeping it plump and keeping it responsive. And so estriol, like I said, and estrogen, even estrogen itself, estradiol, testosterone can help with getting that tissue healthier. Testosterone, though, is not the be-all, end-all of bringing back libido. I have so many women who come in and say, I just want testosterone, give me back my libido. I'm like, whoa. If it was that easy, I would put every single woman on testosterone and call it good because it would be easy, right? But women are very complicated. Hormones are just one part of bringing back a libido. It's everything else under the sun. If anybody's taken a human sexuality class, think back to there is always this picture that they throw up on, the projector, and it's an on-off switch for men. That's his libido. For a woman, it's a multi-circuit board. Literally, right? So, and I always tease women because I'm like, literally, we have to think back and go back to all those simple things. Here's my biggest question. Do you still like your spouse? Like, does he still turn you on? Like, those are the questions I ask because when women say, well, we're kind of having some marital issues, I'm like, I can't give you back your libido if you're having marital issues. I can't just flip a switch and make you want to have sex with him if he's making you irritated or he's making you angry or you're having some issues that are going on. That's where we need to see a therapist. Let's work through things. If it's, he doesn't really tell me I'm pretty anymore, or he doesn't really take me on a date anymore, or we don't really spend time together. We're not actually, having some one-on-one time without talking about the kids or talking about work or talking about that he lost his job or whatever it may be. When we start looking at all those layers for us, women are expected to shut the bedroom door and become sirens, and we don't work that way. We can't just simply shut the day away and go into a bedroom and go, yep, let's have sex. This is going to be fun. Because remember, we don't compartmentalize. Men compartmentalize, yes, sex, you're naked and I'm ready to go. No, it doesn't work that way for me because I'm thinking of all the 10 million things that are going on from the day, right? And so when we are trying to be intimate with our partner, sometimes we have to get back to scheduling of things again. Only if you want to. I bring that up with very delicate kid box. I'm not going to say it very much. Because when you look at human sexuality and you look at sexual therapists that are out there, they'll usually tell you, you got to kind of commit to twice a week before we can get spontaneity to start coming back again. But again, we don't go home and tell our partner, Tammy said that we need to commit to twice a week because if you get to Saturday and you haven't had sex yet, he's going to, do we get it tonight twice? And you're going to be like, no, I'm not interested in it. So that's to be kept to yourself, that we know that there's degrees of intimacy, and degrees of intimacy stimulate oxytocin for women. Men are kind of like that on-off switch, but we all know that we have oxytocin release in other ways. Hugging, being listened to by our partner, him saying nice things to us feeling loved and nurtured in our relationship, feeling like we're valued in our relationship. All of those things matter to us as women in a relationship and sexually. And so it's just important to realize that you seriously are not broken if you don't have a drive. As we age, arousal usually needs to precede desire. And everybody's like, no, I just want to be crazy and like want to have it all the time and I want to chase them around. I'm like, but when you get involved with it, does the arousal lead to desire? And that is Dr. Michael Critchman, who is a leading sexologist in North America, says is one of the most important things for menopausal women to realize is that arousal precedes desire as we age, not the other way around. And that doesn't mean you're broken. That just means that we are changing in the aging process and how we are dealing with our intimacy.